Good afternoon, everyone, and welcome. I'm Linda Schwimmer, President and CEO of the New Jersey Healthcare Quality Institute. Thank you for joining us. While we're disappointed that we aren't together today in person at the Trenton Country Club, we hope you agree and we feel that we made the right decision to pivot to a virtual event given the recent surge in COVID-19 cases. I hope you enjoyed the slideshow that we had at the beginning of the event. It was really wonderful for me to see pictures of so many of you, our members, our board members, our founders, our partners over the years, and both at events at the Trenton Country Club and other places, and within the community, really engaging with one another and doing the work that we do to improve quality, safety, and affordability, to talk about issues that are important to all of us. And even though we're not doing that in person today, we do, again, hope for the day when that is the right course of action. And on that note, we are going to be continuing our celebration of our 25th anniversary. We are planning a big celebration for December 8th at the Trenton Country Club. So please save the date and more details to come on that. And again, I hope you enjoyed seeing all of those pictures. A couple of housekeeping items before we begin our presentations today at the conference. This conference is being recorded. We will be sharing the recording with all attendees and also posting it on our website. All phone lines will be muted for the duration of the program to limit background noise. However, you may ask questions at the conclusion of each speaker's presentation in the chat box. You can also use the reaction box to raise your hand, and one of our staff members will unmute you at the appropriate time so that you can make your comment or ask your questions. Also, throughout the presentations, we really hope that you will use the chat box to engage with us and the panelists and one another. We know that this is an important topic to all of you and that you're not a shy group. So we really would love to hear your input on this important topic. Yep, I think I covered all the logistics. So now let's get to the substance. The topic for today's conference is building a healthcare workforce for the future. In April of 2021, the Quality Institute released a report entitled Emerging from COVID-19, an Action Plan for a Healthier State. The plan consisted of 24 consensus recommendations to drive quality improvement and best practices, and it was informed by the healthcare leaders and others that we interviewed throughout various phases of the COVID-19 pandemic. Recommendations numbers 1 through 7 in that action plan aim to support the creation of a resilient and diverse healthcare workforce. This was a topic that came up again and again across all of the different subgroups of the action plan work group and was probably the #1 priority to all of them. The recommendations around the healthcare workforce led to further work that the Quality Institute has been doing with generous funding from the Robert Wood Johnson Foundation. We've been creating a guidance document which is focused on how New Jersey can take initial steps using data as well as stakeholder engagement to improve its future healthcare workforce. We look forward to releasing that report later in June or July and to working with all of you on the next steps that will come after that release. This conversation and the presentations are definitely part of that work. Today, we are looking forward to hearing from a great lineup of speakers. And again, we hope that you'll engage with them through the chat and by raising your hand. I also want to, before I introduce our speakers, really thank the staff at the Quality Institute. Not only did they plan one fantastic event that was to take place in person, but they very quickly pivoted and planned a whole nother virtual event. And there's so many logistical switches. So I just want them to know that I don't take that for granted. And I hope you guys can give them shout outs for just what professionals and they are and the dedication that they've shown. So thank you to all of you. Now with that, I'd like to introduce our keynote speaker, who we are so honored to welcome. And one day I will meet her in person, Dr. Patricia Simono-Boyce, who's the University Dean for Health and Human Services at the City University of New York. Dr. Boyce started, there she is, Dr. Boyce started her career as a registered nurse in the critical care unit at Bellevue Hospital and has held a series of progressive leadership positions in healthcare systems, state and federal government, and the private sector. Dr. Boyce holds a PhD in medical sociology, as well as master's degrees in sociology, community health, nursing education, and a Bachelor of Science degree in nursing. She's responsible for the portfolio of HHS undergraduate and graduate degrees and credit-bearing certification programs across SUNY's 25 colleges and graduate schools, representing over 40,000 enrolled students. So she is certainly making an impact on the future of the healthcare workforce, and thank you. She is going to share with us her experience at SUNY and within the state of New York and what she's been doing across academic organizations, industry, public health, and other stakeholders to advance the healthcare workforce in New Jersey. And we're hoping to learn from her today. So welcome, Dr. Boyce, and I'm going to let you take it over from here and pop your slides up, and looking forward to your presentation. Thank you.
Thank you so much, Linda. I appreciate that generous introduction. And just clarifying, I am with the City University of New York. Often folks confuse SUNY and CUNY, the State University and the City University, so I'll just clarify that. I'm honored to be with all of you today and try to address the very big topic of building a healthcare workforce for the future. So our objectives for our time together this afternoon are as follows. I'll try to provide a very brief introduction to CUNY and our health and human service programs. I'll also offer some context on the status of healthcare in 2022 and some key healthcare workforce issues and concerns. Then I'd like to transition to some examples of statewide healthcare workforce strategy models and what we are learning across the country. I'll then spend the balance of my time on New York's approach to healthcare workforce transformation, particularly what's happened in the past decade, as well as some current workforce issues and priorities, followed by CUNY's response to the workforce crisis. I'll end our discussion with a recap of some key takeaways today before inviting you to participate in previous discussion. As Linda mentioned, please feel free to share thoughts and comments on chat during the presentation if anything comes up, and we're happy to address any of those questions and more discussion at the end of the presentation. So let me jump in. So as a brief introduction to CUNY, CUNY is celebrating our 175th anniversary. Founded in 1847 as the nation's first free public institution of higher ed, we have a total of 260,000 enrolled students across 25 campuses in New York City. CUNY's mission is to provide high-value education to all students, irrespective of means and background. Thus, we are very proud to be a proven engine of social mobility as we propel almost 6 times as many low-income students into the middle class and beyond, more than all 8 Ivy League campuses, plus Duke, MIT, Stanford, and Chicago combined. I am a proud CUNY alum, and I represent the portfolio of health and human service programs, as Linda mentioned. That includes 40,000 enrolled students across our 25 campuses and covers 60 health and human service disciplines across the 350 degree and credit-bearing certificate programs. It also represents 50 plus nursing programs across our campuses, and that graduate a couple thousand students a year. Forgive me. Now let's turn to the current status of healthcare. For over 2 years since the outset of the COVID pandemic, America's healthcare delivery systems have been on the front lines, really caring for patients, comforting families, and protecting our communities. The pandemic has taken a significant toll on health systems and providers, placing enormous strain on the nation's healthcare workforce, including historic volume and revenue losses, as well as skyrocketing expenses, labor constraints, and the challenge of navigating COVID fatigue and burnout, as well as the ongoing surges. In addition, models of care are shifting at a rapid pace, as all of you know, supported by significant uptick of telehealth during the crisis and the need to manage care across traditional care setting boundaries and developing alternative staffing models to mitigate the shortages. Mental telehealth is increasingly popular as a relatively easy and inexpensive avenue to access therapy and other treatments, while digital monitoring therapies and AI are quickly emerging as solutions to alleviate some of the big stressors on the medical system right now. Though all these challenges are significant, the tightening labor market has surfaced as the most critical that we're facing now. I'm very sorry, for some reason I'm having some challenges with my cursor, but I'll struggle through it on my computer. These labor forces are impacting service delivery with clear risks of patient safety. Our health providers are facing increasing turnover, widespread burnout, and higher staff callouts. There's more spending on salaries that all of us know, bonuses, contracted staff, and other incentives to recruit and retain staff are key issues that are unlikely to abate anytime soon amid greater competition for workers with limited pipelines. Let's take a deeper dive into the current status and projections of the national healthcare workforce. The U.S. healthcare industry employs 22 million workers, which we know represents about 15% of the national workforce. That includes about 1 million professionally active physicians, 5.5 million nurses. Employment is down more than 500,000 since February 2020 at the height of the pandemic, with nursing and residential care representing some of the greatest workforce losses. We have about 9.7 million workers employed in direct or assisted care occupations, such as certified nurses aides, patient care assistants, home health aides, dental assistants. These numbers are expected to grow to about 10.7 million over the next 5 years, leaving an anticipated shortage of 3 million workers as higher numbers leave these jobs with very limited pipeline to replace them. And just as a really interesting point of reference, it takes 4 years is the average amount of time it takes for hospitals to turn over all of their CNA and PCT staff. So we know that there's particular churn with this group. Primary care will also increasingly be provided by non-physicians. We have about 21% of our family medicine, peds, OBGYN, and PCPs eligible for retirement in the next few years, with the demand expected to grow 4% during the same time period. So that will result in a shift towards primary care being provided by PAs and NPs, which is already starting to happen in very high numbers. We also know that the demand for nursing will grow at least 9%. RNs and LPNs, more than 50% for NPs in the next decade. The COVID pandemic has accelerated the nursing shortage. Close to 50% of RNs are over the age of 50 right now, and it's projected that 1.1 million nurses will be needed to replace those expected to retire by the end of this year alone. In addition, the pipeline of nursing is compromised with the current rate of 2 years average time for new nurses at the bedside, and approximately 1 million of those leaving permanently the profession. We know that over half of the US states will not be able to fill the demand. And currently there are about, typically 30,000 plus travel nurse positions open at any one time across the country. In addition, there's an expected 10% increase in demand for mental health workers by 2026. We do expect a corresponding loss of about 500,000 of those mental health workers, with again, a significant impact to half the states who are not able to meet this demand. The result will be a 6-figure hiring rush for mental health providers as that crush continues to expand. So we know the staffing crisis spans all subsectors of healthcare. 31% of hospitals report a critical staffing shortage, with 12 states stating that they have more than 40% of hospitals experiencing this critical shortage. And while hospitals are facing a shortage of workers, patient acuity has also increased with patients staying longer in the hospital. This workforce shortages extend to nursing facilities, where the shortages are nearly as high for nursing staff at an average of 24% as they are for aides. And these patterns have held steady since nursing facilities began reporting this data in May 2020. The staffing crisis is also significant for medical practices, with close to 3/4 of practices ranking staffing as their biggest challenge. As we see here, the turnover rates are considerably high for allied health workforce, as high salaries outside of healthcare employment, especially for entry-level direct care workers, has led to increased attrition from the healthcare workforce. More than ever, healthcare is now competing with other employment sectors for the same workers. We're seeing that quite a bit, as all of you know, with Amazon, big box stores, and the retail marketplace really competing in terms of benefits and remote work opportunities. Since 2016, the average hospital turned over about 90% of its workforce and 83% of its RN staff, which are pretty sobering statistics. The combination of employee burnout, fewer available staff, and increased patient acuity with higher demand for care, especially during the Delta and Omicron surges, has forced hospitals to turn to contract staffing to really help address these shortages. According to data from MC and Burning Glass, there's been nearly 120% increase in job postings for contract or travel nurses from the pre-pandemic levels in the last few years, January 19 to January 22. The average cost of turnover for a bedside RN is $40,000 and ranges from $28,000 to $51,000, causing a hospital to lose approximately $3.6 million to $6.5 million per year. Each percent change in RN turnover costs or save the average hospital about $270,000 per year. In fact, while contract staff nurses accounted for 23% of total staff hours in January 2022, they accounted for nearly 40% of the labor expenses with nurses, with 25% of hospitals having contract nurses account for more than 50% of total nursing costs. There's considerable data on factors influencing staff decisions to leave current positions. The 2021 Future of Work and Nursing Survey revealed that 56% of nurses cited demanding nature or the intensity of their workload as a key factor influencing their decision to leave. More than 50% of nurses identify insufficient support for well-being, with greater trends in staff seeking flexibility and a focus on meaningful work. So what does this all mean? We need to prepare and manage staff quite differently than traditional healthcare staffing models. And as we all understand, a destabilized workforce produces a vicious cycle, compromising quality, safety, and the bottom line. Pulling back a bit, it's important to consider approaches to the current healthcare workforce situation. The question is, how can we transition from a crisis to a workforce stabilization process, aligning our incentives and coordination on common goals with robust solutions for pipeline development and innovative workforce development models to address these urgent needs? We know that the high investments in temporary labor with the focus on immediate vacancies don't completely impact churn, right? We're just kind of managing the churn in a very temporary way, as opposed to a stabilization approach, which is really a focus on these stabilization strategies, a longer term approach that will look at more around capacity maintenance as opposed to really a constrained capacity situation. So how do we prepare? The pandemic has served as a catalyst for creativity, accelerating pre-pandemic expected shortages and delivery model shifts. We need to move our collaborative mindsets with some collective leadership toward a more sustainable workforce model. We also need to manage the shifting care delivery boundaries with a focus on person-centered versus setting-focused care. In addition, new skills are needed to leverage the technology and evolving care models with a particular focus on high-touch, people-oriented capabilities to complement digital skills. Multiple talent and education pipelines are needed with a focus on readiness and resilience. The core skills needed for healthcare really focus around interpersonal skills, We're learning a lot in terms of what the gaps are in terms of transition to practice now, and this has become key for us. Interprofessional teamwork. I think we knew interprofessional teamwork was quite important. There was a tremendous amount of evidence around it, but it has heightened importance now through COVID and as a sustainment strategy. Self-awareness and sociocultural sensitivity, analytical skills with adaptive problem solving, systems thinking, openness to continuous learning, high digital literacy, and comprehensive skills assessment strategies are really on the short list in terms of what we need to look for our healthcare workforce going forward. These shifts have considerable implications for health professions education and pipeline development. Dr. George Thibault, a national leader in health professions education and very thankfully advisor to me at CUNY for our health and human service programs, is exactly on point with his predictions for the future of health professions education. He says we need to focus on interprofessional education as a cornerstone of our curriculum across disciplines. We need to embed longitudinal integrated clinical education experiences, which is turning out to be very key because we know that we can't afford the burden of onboarding and clearances for students going into our very compromised health facilities. So we need to figure out how to embed them longer and create more meaningful learning and clinical experiences for them. We really need to embed much more comprehensively the education of social determinants of health, and also consider the continuum of health professions education. So it doesn't stop at licensing or degree, but there's a continuing development of those staff as technologies, care models, and other modes continue to shift. We also need to focus on competency-based education that has a very strong time variable element into it, and also figuring out how we're integrating AI and new technologies into our health education pipelines. Now let's begin our transition to what we're learning about statewide models for healthcare workforce strategies. We have a number of examples here listed on the left of statewide models around healthcare workforce. They all have very similar areas of focus, such as coordination of priorities among a stakeholder group, strong focus on data and monitoring, financial incentives, both on supporting workforce as well as priority workforce needs, implications for education and training, strong focus on regulation and policy, such as scope of practice and licensing, with implications for practice, recruitment, retention, and pipelines. These statewide models have a common approach across most of them around data, strategy, planning, and evaluation. What we see here is that those states that have had some success with their statewide healthcare workforce approach have had a number of effective criteria that they've identified. The first being collaboration among stakeholders. The second, and equally important, is a consensus and commitment to data and research around healthcare workforce. The third is incentives to address those needs, particularly in underserved or underrepresented areas across the state, as well as innovative approaches to training and service delivery, mechanisms to evaluate the impact of these efforts on cost, quality, and access to care, and also mechanisms to disseminate the findings to inform programs, policy, and funding. So real direct communication of what the workforce is doing and what the needs are. We'll now turn to what we're doing in New York, starting with the current status of the New York healthcare workforce. In New York, healthcare employment is, this is a quick look of, forgive me. The healthcare employment is 3% below pre-pandemic levels, 11% below what we need actually for this year in 2022. Healthcare employment in New York is expected to grow by 32% by the end of this decade, with an expected shortage of at least 39,000 nurses and 17,000 physicians. The strongest employment growth in New York is in home care and ambulatory care settings, again, reflecting that shift in terms of practice settings. MPs and PAs are expected to have the greatest growth in terms of New York licenses have had the greatest growth in New York licenses in the last 4 years, while the number of clinical lab technicians, technologists, and LPNs have declined during the same period. Home health aides, patient care assistants, and RN demand is projected to grow at the fastest rates. RN graduations are stable right now. They may be experiencing a dip because we're actually starting to see the constraints both on the clinical side as well as the faculty shortages, though they have remained stable during the pandemic. And we have had a corollary increase around certain graduations, such as social workers, with great variability in our private versus public education program enrollment across the state. We've also experienced critical shortages in allied and behavioral health workforce, particularly in rural and urban underserved communities across the state. Now, a quick look at some of the staffing challenges by sector. As you can see, we're relatively similar to the national benchmarks in terms of subsectors of healthcare in the state, probably a little less in terms of the percentage of hospital-based care and a little higher with the ambulatory and nursing facility care. So what do we know? Because we do have a strong focus on data collection in the state. We're always looking at what we're looking around recruitment, retention, and all these other variables on the workforce. So the most recent data tells us what really is bearing out with the national data in terms of recruitment and retainment issues. Hospitals are experiencing the greatest challenges recruiting clinical laboratory technologists and technicians. 90% of them say this is a very high challenge. 90% equally say that nurses and psychiatrists are also equally as challenged to recruit. And this is mostly due to workforce shortages, just not enough available right now in terms of demand. Federally qualified health centers in our ambulatory care are experiencing difficulty recruiting family and internal medicine physicians. About 25% of them, a little less than that, are experiencing some challenges recruiting social work, nurses, and psychiatrists, and they attribute these challenges to workforce shortages, also wage gaps. They have a greater challenge in terms of the wage gap, and geographic location and the populations served is also creating some of that gap. Nursing homes, LPNs are in high demand. 86% of our nursing homes and residential care facilities expressed really difficulties recruiting LPNs. Experienced RNs follow that at 85%. CNAs, it's at 80%. And they're really struggling around newly licensed RNs. Okay, it's most difficult to recruit newly licensed RNs due to the competition with the rest of the workforce. And home care is experiencing great challenges. 80% of them are communicating challenges hiring home health aides, personal care aides, and they are saying that they're most difficult to recruit due to shortages and unemployment benefits during COVID that still are actually impacting their recruitment issues. On the retain issue, so issues similar, but not exactly. Some of the issues around retaining staff. Hospitals are experiencing a little bit more challenges on the psychiatric, retaining psychiatrists. Surgical technicians also come up in terms of retaining them. RNs and respiratory therapists are also most difficult to retrain, often mostly due to wage gaps and competition across employers. Support personnel are a significant factor for the federally qualified health centers in the ambulatory settings. Again, most difficult to retain due to wage gaps and shortages. Nursing homes, again, newly licensed RNs are difficult to retain as they are to recruit, and followed by home health aides and LPNs. And home health care similarly have challenges retaining personal care aides, home health aides, and homemakers. And again, that's really mostly due to the competition from other sectors for these entry-level workers. Now we'll look a little bit at what New York has addressed around healthcare workforce transformation over the past dozen years. So New York spent the second decade of the new millennium working on healthcare transformation with a strong emphasis on workforce. We actually started with the 9-year Medicaid redesign initiative in 2011. That was part of what we then launched around a delivery system reform incentive payment program for Medicaid. That was supported by a Medicaid waiver from the government, with a tremendous amount of spending directly on workforce transformation during that period. That was complemented with a simultaneous grant from the Center for Medicare and Medicaid Innovation that supported a state healthcare innovation plan that overlapped with that work in terms of the healthcare transformation efforts. And both of them actually spawned a number of direct subcommittees that focused on workforce transformation. The priorities in those efforts for the last decade were around sufficient supply and distribution of primary care and behavioral health care providers around the state, looking at workforce diversity, workforce training programs, thinking about standardizing roles and related competencies, particularly in high need areas and community-based settings that really impacted Medicaid utilization. Scope of practice optimization, healthcare workforce data gaps. We do have a very strong data collection process in the state, but we actually kind of tighten that up a little bit more during this transformation effort with a strong emphasis on these data gaps. Also preparing for emerging models of care. What we saw is that shift, which is why it was really important to think about the distribution of that care workforce into these different settings. And then addressing statutory and regulatory barriers to effective team-based care. So some other examples of things we did in this area are recruiting kind of high need and emerging titles. We actually worked with around the state high schools and institutions of higher learning to develop workforce pipelines. We created new college credit bearing and certificate programs for emerging titles, and some additional kind of targeted training initiatives that were standardized across our networks around the state. New York has built a considerably strong foundation on healthcare workforce data with the Center for Healthcare Workforce Studies and associated partners who actually prioritize data collection and monitoring on the supply, pipeline, and demand for the healthcare workforce. The Center for Healthcare Workforce Studies was established in 1996. It's a center within the SUNY Albany School of Public Health. It's one of 9 HRSA-sponsored healthcare workforce research centers in the US, and the only one that also includes a focus on oral health providers. It's committed to collecting and analyzing data to really understand workforce dynamics and trends, and it really intends to inform public policies, the health education sectors, and the public. So it works very closely with these key stakeholders across the state. Just a quick review of what we do in terms of the data, supply, pipeline, and demand. So we have the Center for Healthcare Workforce Studies that work with the Department of Health at the state and the Education Department on ongoing registration surveys. There are voluntary surveys that happen on a regular basis. Those started in 2010. We also have mandatory NP license renewals that was instituted in 2015. And then we've just recently passed legislation to include mandatory renewal surveys for all other health professions. In addition, we use the physician profile reports with a little tightened reporting requirements in the last few years to track physician data, supply and demand. On the pipeline side, the Center for Healthcare Workforce Studies surveys programs and our new graduates very frequently. They very traditionally send out annual nursing dean and director surveys. I was just actually looking at a draft of their survey this morning and adding a few questions to it. They do an annual resident exit survey on demand. They do surveys of HR directors in hospitals, nursing homes, home health agencies, and clinics. On the demand side, the center actually looks at annual recruitment and retention surveys of healthcare providers, again, across all of the subsectors. So we know the value of data here is really making sure that we're providing some critical information to these stakeholders on the patterns, which include the shortages and the distribution of staff across the state in different jurisdictions and setting types. It also helps us really understand demographics, underrepresentation across occupations and jurisdictions, and informs these workforce development programs, what we need to really address these critical gaps, as well as evaluate the impact of our recommended changes. Some of the focus areas during this time have been, again, improving that data and information, increasing workforce capacity to meet demand, collaborating to address these training gaps. So there was a lot of standardization around training and a lot of resources that were shared across our networks in the state around healthcare workforce training. There was also TA on workforce development as part of the healthcare transformation efforts, and a lot of work on job clarification and roles and associated competencies. That's still going on, a lot of the competency development work, particularly for emerging titles. The lessons learned in the last decade was that shared responsibility for workforce transformation is critical, both public and private partnerships. A step-by-step approach is also necessary to prepare and implement a statewide workforce effort around healthcare. A standardized set of tools and support should be available to assist in workforce transformation efforts, and it's all highly dependent on consistent data and metrics to inform workforce planning. The state now is pivoting in terms of where we are at, this stage of the pandemic. And our goals right now from the state are to grow the state's healthcare workforce by 20% over the next 5 years, retain the existing workforce, and advance health equity. So very ambitious goals, particularly around workforce. There are a number of different priorities to support those goals. So there's a tremendous amount of investment right now in healthcare workforce. There's targeted education innovation funds. I mentioned the Health Professions Information Bill that will now go into effect in terms of monitoring licensure and, again, the supply and demand data across these different disciplines. The state is also looking this year, getting ready to stand up a new statewide healthcare workforce innovation center. So that will take the learning and some of the activities we did in the last decade or so from those subcommittees and actually put them into a much more centralized and standardized approach with our stakeholders. There's also financial support for hospitals and career pathways, looking at how to support preceptor development. And the state launched actually in the last year a New York State Public Health Corps to really address some of the immediate needs on building resiliency for public health. So just a quick look at these investments. So there's in general $5 billion for pay reform and bonus wages. They cover healthcare workers, mental health workers, human service workers, and home care workers. There is financial support for career pathways for those entering the healthcare industry and for current workers to advance their careers. That includes everything from nursing scholarships, stipends, wraparound services, also work going on with labor unions to actually build those pathways for members to advance in these high demand roles. There's financial support for hospitals to cover the cost of new training programs and compensation to allow personnel to train full-time support staff to support that training, pathways and opportunities for long-term care workers, and payment parity for telehealth services. Again, trying to take care of the distribution of services in these shifting settings. So some example, there's a lot going on right now in New York State around innovations, and I'm sure it matches a lot of what's happening in New Jersey. So just to go through that quickly, we're learning that nurse residency programs are those programs that are undertaken by health systems for new nurses in their first 1 year or possibly first 2 years after graduation have been very successful. There's been some investments in them in the state. New York City Small Business Services invested in them in the last few years and are continuing to invest in them, supporting our healthcare systems. They have expanded now, so they are expanding nurse residency programs to specialty units, to long-term care, to correction care. So it's really kind of taking off in terms of what the possibilities are. And this is just added support, professional development, skills building, and kind of really helping new staff develop a professional identity in their roles. We're also revising licensing and credentialing pathways. We learned a lot around executive orders during the crisis. So we're looking to see what some of those changes, how they can be made permanent, working with regions and others around the state through the education department to see how we can make recommendations in those areas. Also very rapidly evolving staffing models, looking at team-based care, virtual care models, tiered staffing, looking at digitization, automation of a lot of the recruitment and onboarding efforts. It's particularly taxing the health systems that are addressing really crunched and continued churn around onboarding new staff. Folks are looking at upending traditional work environments, trying to allow the greatest percentage of telework where they can, creating pathways to advanced practice, looking at clinical ladders, focusing more on not just tenure, but actually accomplishments so that they can kind of give folks advancement in an easier and a more streamlined way. Reinforcing the value of bedside experiences, looking at a lot of middle management supports. That entry-level manager and early manager is something that is a linchpin and particularly vulnerable in many of our healthcare settings. So looking at how we can provide additional support for that level of staff. Looking at legislation on simulation. So we're requesting that at least that our nursing education programs can use can apply 1/3 of their clinical experiences to simulation. So that hopefully will go through shortly. We're also doing scope of practice reviews for high demand roles. Again, looking back at the executive orders during the pandemic, see what we've learned from that. Increasing flexibility, a strong demand that's somewhat generational in terms of what the new workforce expects. professional development and continuing education. I just spoke with an HR director of the largest public health system this morning who told me it's a very shifting environment in terms of what staff are asking for to be hired. And it's a lot of investment in terms of where their professional career can go. So we're working collaboratively with many of our partners on how to support that ongoing development of new and experienced staff. A lot of work on bridges, pathways, and ladders to high demand roles, and a lot of efforts, as I'm sure all of you are doing, on retention. Just a quick recap of what's happening at CUNY around our kind of response to the healthcare workforce crisis. So we have initiated a healthcare workforce research group with our external partners and the Center for Health Workforce Studies. So we're gathering data, conducting some research, engaging folks in kind of rapid fire focus groups, key informant interviews, and others, just to kind of get a real clear understanding of some of the key pain points, some of the innovations that are happening. Our interest is trying to address pipeline issues as well as expand and scale innovations. We also want to use some of this data collection to inform what will be our new Healthcare Workforce Transformation Center. So it's really kind of, we're trying to be very timely in terms of how we collect and collaborate and aggregate this information. We're also working with many of our health system partners on jointly sponsored healthcare workforce research. We have formed several and are looking to expand on our academic practice partnerships. CUNY does not have a dedicated health facility or a partner health organization. So we are very dependent on our relationships with partners in New York City and beyond. So we actually have had some successful academic practice partnerships in the last year or so that's really supported our efforts in really coming up with a shared agenda around professional development, shared work on some research priorities and other particular interests of our clinical partners. We are looking to develop stakeholder advisory groups to inform kind of our evolution with curricular and training experiences that most meet our partners' needs in terms of workforce demand. And we are actually incorporating design systems thinking to reimagine some of these partnerships. So we have some wonderful folks we're working with, design system consultants who are working with us to reimagine those relationships and I guess redefine what we call our ecosystem of health professions, education, and affiliate relationships. We also learning a lot. So, lots of issues around generational shifts in terms of the workforce, transition to practice gaps, evolving student training models. We're being very innovative in terms of expanding our placements by being very innovative on what our placement sites are asking for. So they don't, it's more burdensome for them to have students for a limited number of hours, for example. So we're trying to shift to things like longer shifts. And our students being involved in the handoffs and some of the interprofessional education that's happening at the health setting. We're also helping folks address these capacity constraints. So if we're hearing from our partners that they don't have staff to precept students, we're working with them on preceptor development so that they can, it's win-win, they can develop their capacity and we can actually bring in students to support their pipelines. I'm particularly very passionate about interprofessional education. I started a university-wide education interprofessional education initiative when I got to CUNY. It's continued to expand. It's been critically important during COVID. And we're hearing from our partners that we can't do enough to help our practitioners be more prepared for team-based care. So we're really focused on that. And also just working on innovative pipelines to high demand roles, lots of ways to kind of work with incumbent staff and others to build those pipelines. In general, I would say our focus around workforce stabilization is 4 key things around career readiness, capacity, career ladders, and really these critical competency-based skills. This is what we've been really focused on for at least the last 9 months, and we've been working with our partners on. And we're really, again, focusing on facilitating what's needed right now, which is entry to practice, degree completion, hiring pathways, and advancement. Number of ways we're doing that. So increasing awareness and incentives for high demand careers, both within our campuses and with other partners, high schools and other vocational schools. A lot of preceptor development, as I mentioned, and staff mentorship at our clinical sites. We're pairing nursing leaders, for example, with nursing faculty to support their efforts around preceptor development, embedding nursing education students in certain places, working with retired clinical laboratory technicians who are actually mentoring students and staff and some preceptors. So lots of innovation on that front. We're also working on innovative strategies and models around clinical training. We're certifying enrolled students so that they can actually get practice-ready experiences, getting them certified as nurses' aides, as phlebotomists and such, so they get, again, that experience and help the workforce shortage needs. We're also implementing, piloting a number of dedicated educational units, longitudinal placements, and such. We're working on strategic partnerships, as I mentioned. We're expanding our efforts with labor unions, looking at employers around cohort admissions of incumbent workers for high demand training, such as medical lab tech, respiratory therapy, and such. We are doing a tremendous amount of work with bridge programs, career ladders, and have expanded all of our work around credit for prior learning, so that we're really recognizing experience and credentials and kind of advancing folks more quickly into these degree pathways and certifications. And really, again, along that front, looking at accelerated multimodality and part-time programs, and with a very strong focus on health equity, interprofessional practice, and really bridging the gaps around transition to practice. Just a few takeaways. I did want to leave some time here for questions. Can't stress enough the importance of stakeholder collaboration to facilitate these pipelines and capacity needs. There's tremendous amount of opportunity. I know I work with our city, state, and industry partners pretty regularly, and I think this just the opportunity is ripe with innovation and eagerness for us to work together and figure out how to address these concerns and challenges. It's so critical to have consistent workforce data and research to inform policy, funding, legislation, and practice. So that's really a key thing. We're highly dependent on it. And I work so closely myself with the Center for Health Workforce Studies. I look to them all the time in terms of what's happening. I build in grants where they can actually be part of those grants and work with us on our particular needs around workforce and healthcare. So, and others look at them very similarly in terms of a critical partner for this work. Workforce readiness, we need to look at workforce readiness as important as the workforce crisis. So really, how are we thinking about preparing the incumbent and future workforce for what's happening now in the shifts? Care models that rely disproportionately on nurses are really no longer sustainable, particularly where we have this tremendous gap. Assistive personnel can't be overlooked anymore. They're critical for workforce stabilization. So the goal here is really investing in these entry-level roles to solidify team-based care. Embracing flexibility on everything from roles, schedules, management training, partnerships. Innovation is needed in everything from technology, culture, talent acquisition, and a lot of staff management. Optimizing our assets, resources, and personnel. Focus on retraining and upskilling to meet the critical needs, and collaborating on these accelerated pathways and career ladders. There's so much we can do together as partners to really expedite entry into these high demand roles. Thank you. I know I talk very fast, but I'm happy to address any questions and comments.
Thank you so much, Dr. Boyce. And, you know, we're from New Jersey, so New York talking fast, it's fine. We're just, you know, over the river from you. We really appreciate the time you spent with us and our members and all of your expertise. It's really, it's evident how much work you've put into this. And I love the way you frame that this is really all about having a workforce stabilization process as opposed to approaching this in terms of managing the churn, which is obviously not as sustainable and not as intelligently thought through. We already have a number of questions, which I'll share, but I just wanted to remind everyone else, if you have a question that you'd like discussed, please go ahead and put it in the chat now. So one of the questions that came through is, and this is really either for you or data that the Health Workforce Center would have that you're aware of, any reliable data which measures the clinical capacity for clinical training in New York State. I think that there's a interest in that here in New Jersey. So yes. Yeah.
That's a great question. And yes, we have been looking at that, which is why we know that we have a tremendous gap. And there's state investments around the preceptor support, knowing that because our health systems are constrained, they can't take students. And that actually needs to be addressed, which is why we're looking at that. I think they do have very specific numbers on that. I haven't seen them myself, but I can certainly ask to find out kind of how they're measuring that.
That would be great. And I guess that's maybe a broader question is how does the center publicly report or share or post that data?
Yeah.
And
Yeah.
what are what you would describe as the best strategies for that to make the information as actionable as possible?
Yes. So they do a number of things. So they have a pretty robust website where they don't only post their reports, but they also post every presentation they do, which I find equally as important. So if I've known, for example, that they made a presentation at a group because I was in there and there were a couple of relevant facts that may not have been in a report, but actually were pulled out for a presentation, I'll remember to go back and look at that because that might have a particular piece of information that's useful. But in any way, it's just kind of a nice complement of that. They also run, I think, this healthcare workforce. I forgot the name of the website that actually looks at all the healthcare workforce data around the state, and it's very kind of interactive. You can put in some variables and such for that. And Tyler's putting their website in there so folks can look at it directly. But yeah, it's a matter of the transparency of the data and reports. They also present to stakeholder groups very frequently, so stakeholders receive that information more directly. I, for example, have council meetings of all my deans and chairs on each semester, and I'm actually I bring them every year or two in. So I'm bringing them in now, actually at the end of this week, to a council meeting at CUNY for Health and Human Services to present the state of the workforce, what's happening. And half of that meeting time is a discussion with our deans and chairs about impacts on education and what they're seeing, both in terms of their relationships with providers, readiness for students and such. So, but others equally invite them in terms of an active contributor to their work.
That's great. And just so everyone knows, we are going to be sharing Dr. Boyce's slides, this recording, and we'll share the link to the Health Workforce Center's information as well. So to your point, another question that came through, which I think is important, is what are the metrics for the progress and success of all of the innovations? So maybe not all of the innovations, but some of the innovations that you mentioned. So for instance, the investments in the center and some of the investments in innovations and team-based care and other things that you mentioned, how is the state measuring those things?
Well, I think that's a great question. And I'm really thrilled that they made this very kind of big and audacious goal of 20% growth in healthcare in 5 years, because that's a yardstick that we all have right now. So everything's got to add up to that in one way or another. How are we increasing the workforce? Because it's not sustainable unless we actually are making direct efforts toward increasing it. So that's one big metric around that. In addition, we're expecting that the Healthcare Workforce Center, the Healthcare Workforce Innovation Center, will be developing a set of metrics that will be kind of directly related to that larger goal. And they are actually embedded in the New York State Department of Health, which makes a lot of sense because they'll be monitoring that and working closely with the State Education Department and other stakeholders to see where we are along those fronts. So there's a number of, I think, metrics. And we were pretty good at that during DISRIP and the state innovation transformation work in terms of very, very targeted metrics on our work. So.
Okay, I'm getting some great questions, so I'll go fast. This might be more for the stakeholders that you engage with, but if you have some thoughts,
Sure.
New Jersey, like many other states across the country, this isn't just us. There are delays and challenges in getting people licensed as quickly as possible. Wondering if through your work and collaboration, you've seen improvements on that front or have suggestions for us.
Yes, so we are seeing some improvements. In particular, New York has had a relatively archaic way of accepting licenses from out-of-state licensed technicians and technologists for clinical laboratory work, and they're just making much needed changes in that. Typically, they'd have to go through an extensive review, they'd have to fill some state requirements. It would slow folks down or mostly discourage people from coming in from out of state, even if they had 20, 30 years experience, to actually then be licensed in New York State. So they are doing a lot of work on that. They've expedited those processes. They've changed the policies. I mentioned earlier that we're looking at scope of practice, licensing, credentialing pathways. So there's a tremendous focus on that, particularly since COVID. And then, as I mentioned, I do think, and I'm sure you experience are very similar changes. When we had to, the executive orders that were put in place made things work. So I think we learned a lot from them, and many of us are pushing. I mean, during the executive order time, I had my two little Sharpies with my color coding that I kept track of which one should stay, which one should go. Every time there was another one that came in, I actually color coded them. And then I sent that to all the regions in the state saying, this is what we should continue to do. And they said, okay, not that they've done them all, but I know that they're all under consideration because of the tremendous impact they had in the short amount of time.
Yep, I'm sure that many of the people on this call have done the same thing. They probably didn't all use the same color, but they did the same thing.
I'm sure they have.
So another question was, you talked about the changing type of practice, so this person is asking if you've seen through your education a reluctance or pushback in any of the fields on some of the changing scope or innovations, changes to telehealth, or just way things are done, and kind of then, to the extent you have, how has that been addressed or mitigated?
Excuse me. Yes, I keep hearing and seeing and experiencing myself tremendous generational differences in these points. As I mentioned, I had a terrific discussion with a colleague this morning focused on a couple of areas, and she expounded about the generational shifts quite a bit in terms of workforce, not just with recruitment, but with retention, and about the shifting staffing models, and folks who gave really interesting examples of folks who, come in for entry-level positions, and if they're not moved in a certain, period of time, they're more likely to leave. All these other issues that are contributing to that. But yes, a lot of issues in terms of the generational aspects of where folks stand in the workforce, the expectations around flexibility, the conflict, the cultural conflict of these different generations kind of working in a very stressed environment is also contributing to kind of culture clash right now. That comes up quite a bit.
Yeah. Well, that will keep you gainfully employed then, I suppose. So one last question, and this is, a tough one, but I'm wondering if it comes up again in some of your stakeholder engagement. Just the issue around the role of reimbursement and how much of that question is, and the barriers, and particularly around primary care. So there's this discussion about family physicians, nurse practitioners, team-based care. And I think sort of the question is really asking, aren't they all sort of bumping up against the barriers to how we reimburse for primary care or family medicine, and what could be done about it? And how could we use some of the data that you're collecting to address it?
That's a great question. So some of the things we're seeing is, yes, that's critically important. And it is what is impacting these ambulatory care settings greatly in terms of them being able to hire and retain staff, because they can't compete with the larger health systems, mostly because of their reimbursement models, right? So there's a lot of look at that. In addition, you see the state has made some move in New York around kind of payment parity for telehealth services. So again, that's some recognition that they need to look at the models of care and how they're reimbursed in different settings. There's a lot of recommendations that are going to the state around these ambulatory care models. And as the shifts happen, because we have more capacity constraints in the inpatient setting, how are we actually looking at reimbursement? So that's happening both on the scope of practice as well as kind of the payment model. We are hopefully about to get another waiver, a Medicaid waiver from the government. And I know that there's a tremendous amount of thought that's gone into considering payment model redesign that matches our efforts from the previous Medicaid waiver to support these ambulatory care practice needs. And it does directly impact workforce, as you said, but more importantly, there are fixes that needed to have been made for a long time that probably will be made in some cases now.
Great. Well, thank you again so much, Dr. Boyce. It was really a pleasure working with you on this initiative, and I know that we'll continue that collaboration. So we really appreciate you spending some time with us this afternoon.
Thank you very
so
much.
much.
Thank you.
So at this time, I'm going to turn things over to my colleague, Tyla Hausman, who's going to monitor our next panel. Tyla is the Chief Operating Officer at the Quality Institute. She's been with the Quality Institute since 2016. Prior to that, she worked in various roles at the New Jersey Hospital Association and with the state in the governor's office and for various senators and assemblymen. For those of you who know Tyla, you know how fantastic she is in all things. And we rely on her to advance our work in improving safety, quality, and affordability. And Tyla, I will let you introduce our first panel. And are you on? Great. All right. Thank you so much.
I'm here. Thanks so much, Linda. And I'll just reintroduce myself as Tyla Manier, to make sure I get my last name in there. I know my husband's on. So thanks so much for having me. Deanna minus Vincent could not be here as our moderator today. So we wish her well and hope she'll be with us for a future event to moderate or speak. So I am happy to take her place today and moderating, creating a diverse healthcare workforce through community engagement and early career education. And as Linda mentioned earlier, we released our action plan last year and are fortunate to be working with the Robert Wood Johnson Foundation on continuing some of our recommendations from the action plan to further support and develop our healthcare workforce in New Jersey. And so part of that work is creating a guidance document for policymakers, for the public, for all of us as industry stakeholders to help support creating greater transparency in data in the healthcare workforce, and then also creating a mechanism in the state to analyze that data and then further make recommendations, much like a lot of what Patty talked about, which is why we were so fortunate to have her as our keynote. So we're excited to be doing that work, and we'll be excited to share it with all of you in June or July once it's released. Part of that work was interviewing stakeholders from across the state. So I'm sure many of you who are on were interviewed for the project, and we're fortunate in that all of our panelists that are speaking with us today were all interviewed, or their organizations were interviewed for the project. So that's how we came to choose these panels and choose these speakers. We thought these were topics that really resonated and really are things that other folks are thinking about and working on across the state. So with that, I would love to introduce our panelists. First, we have Taruna Chujaria. She's the Assistant Director for Special Programs at the Cooper Medical School of Rowan University. Taruna is an educational professional with 15 plus years experience in higher education. Her expertise includes student advising and program development and implementation. She's a transformational leader with a proven record of success in recruitment and retention of students from diverse backgrounds. Ms. Chujaria has a master's in education from Rutgers University, New Brunswick, and has previously worked within the Office of Diversity and Academic Success in the Sciences. She has extensive experience in working with students from traditionally underrepresented, disadvantaged backgrounds, and has been impactful in guiding them through their journey within the health professional fields. Welcome, Taruna. And next we have Donna Custard. She is the president of the New Jersey Chamber of Commerce Foundation. As the president, Ms. Custard is responsible for directing program and service initiatives that help drive current and future members of the workforce to be globally competitive, successful members of society. Her more than 30 years of nonprofit experience includes serving as a Peace Corps volunteer in Ecuador, exploring executive for the George Washington Council, Boy Scouts of America, and working with the Educational Testing Service. Donna's experience has focused on education and workforce development initiatives and includes major fundraising campaigns and program design and implementation for systemic reform. Thank you, Donna, for joining us. So let's get started with some questions, and please, folks, start to add some to the chat as we're speaking. Taruna, I'm going to start with you first. So I had an opportunity to interview your colleague for our workforce project, and she told us about some amazing programs that you guys are running at the Cooper Medical School at Rowan University to help expose young people and students in your area, especially in Camden, to careers in healthcare. So can you tell us a little bit about those programs?
Absolutely. So we offer 3 pipeline programs that range from elementary school all the way through college. At the elementary school level, we offer a program called the Primary Urban Partnership. And this program provides our 5th grade students in the city of Camden early exposure to the health professions. So we partner with 2 schools in Camden, and our faculty and students actually visit these schools once a week and engage our 5th graders in science-based activities. So kind of giving them that early exposure, showing them that, you know, science is possible, even if you live in Camden. And our medical students really serve as a role model to them. At the high school level, we offer a program called the Junior Urban Medical Pioneers Partnership. It's called the Jump High program. And this is geared towards 11th grade and 12th grade students in local area schools. So the program provides mentorship and exposure to students that are from traditionally underrepresented backgrounds. We have sessions for them once a month on a Saturday. We offer 7 sessions throughout the course of the academic year. We select about 30 to 35 students that come to our medical school on a Saturday. They give up their Saturdays from 9 a.m. to 1 p.m. And we, again, give them some hands-on exposure to the medical field. We have physicians from Cooper Hospital, our faculty, our medical students that engage in teaching them specific topics and having them, do hands-on activities such as taking blood pressure, how do you suture, learning about cardiology. So we give them that exposure over this 7-month period. And we've seen some success in the sense that the students continuously come for the 7 sessions. All students that have participated in the program over the past 2 years have enrolled in college with an interest in a science major. And really at the college level, this is one of our primary recruitment tools to really diversify the healthcare workforce, is called the Pre-Medical Urban Leaders Summer Enrichment Program, also known as the PULSE program. The PULSE program was launched at the inception of Cooper Medical School in 2011. And the goal is to really recruit and engage students that are underrepresented and are enrolled in a college or university nationwide. So we have students that attend this 6-week summer program from anywhere in a college or university nationally. And they also are disadvantaged or underrepresented in medicine. We offer 3 phases to the students, ranging from phase 1 to phase 3. They're provided academic instruction. They're provided opportunities to do service learning in the community of Camden. We pair with organizations in Camden. They also, based on the phase they're placed in, they also get to do some shadowing at our hospital and do research with our faculty. We also provide these students with workshops that really help their professional development. So if they are students in phase 1 of the program, we make sure we provide them academic skills programs. We provide them workshops that exposes them to various health professions, not just medical school, PA school, PT school, podiatry. When they're students, if they're students that are in the last phase of our program, we provide them interviewing skills, personal statement help with their application. And students are able to participate in more than one phase. So if they come back, if they do phase 1 this summer, they can come back for phase 2 the following summer and the year after. So our goal really is to provide them this exposure, provide them with role models, mentorship. We have sessions where our physicians from the hospital come and speak to the students about their specialties, their journeys, and the challenges they faced. So we really help our students diversify their academic portfolio as well. So that when they're ready to apply to a postgraduate program, they are competitive. We also instituted an MCAT preparation program during the academic year, because we realized that students face several challenges, and we want to make sure we, bridge that gap so our underrepresented students have those opportunities to be accepted in any program that they want to attend. So that's a brief summary of all the programs we offer at Cooper Med School.
That's wonderful. Thank you so much. One of the overwhelming things that we heard from a lot of our interviewees for the project was we need to start earlier. We need to start, educating people and giving people opportunities earlier and earlier, because there's an interest there, and to try to, capitalize on that opportunity. One quick follow-up question. How are some of those programs funded? I think you get grants for some, but I'm guessing there's a lot of volunteer work that happens.
Yes. So obviously the institution supports us to a certain extent in terms of funding within our operational budget, but also, yes, we have applied for funding. We've been funded in the past through the Schwartz Foundation, the Dalfinger Foundation. I have also collaborated with the Educational Opportunity Fund program of New Jersey that has funded us for the past 3 years to support students that are part of this program. The Educational Opportunity Fund program is primarily supporting students that are educationally and are academically disadvantaged in New Jersey. And there is an EOF program at every college and university. So we've collaborated with, the Secretary of Higher Education to receive that funding so we can support these students in our summer program.
That's great. Thank you so much. And Donna, moving to you, how does Jobs for America's Graduates New Jersey help prepare youth of great promise for career advancement opportunities? And maybe you can tell us a little bit about who Youth of Great Promise are and why they're called that.
Sure. Thanks, Tyler. And Taruna, I love your programs. I'd love to talk with you offline more about them.
Absolutely. Thank you.
So Jobs for America's Graduates New Jersey is part of a national initiative called Jobs for America's Graduates, or JAG. And when we talk about youth of great promise or opportunity youth, it's people positive language that we use around students who are formerly known as at risk. So these are students who have lots of potential, but they also have lots of barriers and lots of obstacles preventing them from graduating from high school. The purpose of the JAG program, well, first of all, it's a national initiative. It's in 40 states. It's been around since 1979. And its purpose is to help young adults prepare for not just graduating from high school, but for life after graduation. We are measured on our outcomes, which are obviously the graduation rate, and in addition, what percentage of our students go on to any post-secondary education, military service, or directly into employment. The program is integrated into the curriculum of our partnering high schools, and it is a credit-bearing elective course that these students take. There is a three-prong approach that is implemented as the model across the country. The first is trauma-informed care and instruction. Students in the schools that we serve, and they're typically low-performing school districts where there is a high population of minority students. About 90% of our kids are low income, 45% are African-American, and 36% are Latino. And this trauma-informed care and instruction comes from a place of what happened to you instead of what's wrong with you, which starts to address the equity issue that so many minority students face, in that if behavior is disruptive, it's automatically there's something wrong with you, rather than getting to the root cause of the problem that so many of my students experience. I didn't have anything to eat this morning. I was up late doing homework because I had to care for my younger siblings, or I have to work to help to contribute to the household income. There are just numerous barriers that come into play with our young adults. So it's incredibly important that we address the trauma that has been affecting them throughout their entire lives. We also have a JAG specialist in the class. This is a certified teacher that gets specialized training through the Chamber of Commerce Foundation to become that stable adult entity in the lives of our students. They develop a trusting relationship with the student in order to address the issues that they face. The second prong of the model is employer engagement. So we develop partnerships both statewide and locally with employers, all different kinds of employers, to come in and talk to the students about in-demand industry sectors and the career pathways, educational requirements, advancement opportunities, and salary ranges of those positions. We do this across pharmaceutical industries, fast food restaurants, healthcare, any and every industry that you can think of, because many of our students do work while they're in high school, again, addressing that low income strata. So what we've talked to them about is not just looking at as a part-time just for now opportunity. McDonald's is one of our partners, for example. It's not just flipping burgers and making French fries, but there are career pathways. And if you're already there as a part-timer, how can you segue that part-time employment into something that could become a career path for you? Again, talking about low-income students, they are eligible for EOF, as Taruna alluded to. They're eligible for Pell Grants. Many times they do not pursue post-secondary education. So what are some other ways that you can have career advancement? So we talked to them about those opportunities that may not include post-secondary education. The third prong of the model is project-based learning. And this gives students voice and choice in their education. And what it does is it presents the students with a problem or a dilemma that needs to be solved. They work in teams to manage the project, move it along, stay on time, stay on course, hold each other accountable, and then to present their solution at the end of the project. Some of these are a couple of weeks, some of them are several months long. It really simulates project management in the real world, and it helps the students to reinforce the employment skills that we're developing throughout the year. So this overall initiative really helps young adults of great promise who are often overlooked in their schools to prepare for any career that they may choose. And our success rate in schools across the state is 93 to 100% graduation rates in schools that typically have 36 to 88% graduation rates. And we typically draw from the bottom academic quartile. So very, very successful program based upon this model.
That's amazing. And Donna, I'm just going to follow up on that. In the legislature, there's a bill before the legislature right now that would create a pilot project within JAG-NJ to encourage students in underserved high schools to pursue career opportunities in the healthcare field. If that bill were to be passed, how would that program benefit the students that you work with?
Sure, it's Bill A1311. And what it would do for our students is, and I loved what Taruna was talking about with the integration of what she's doing with other elements such as EOF funding, which breaks down silos. So it seems like what Taruna is doing is incorporating so many disparate elements into one cohesive network, which, you know, gee, that's such a novel idea. We should all be doing that. And that's what something like a 1311 would do. Our students typically don't know what they don't know. And many of them don't know what they would like to do after graduation, or they have aspirations that may be difficult to obtain. On any given day, if I walk into a classroom, what do you guys want to do when you graduate? We've got every TikTok influencer, we've got the next LeBron James, the next great entertainer. We have all of those kids. And I don't like to squash dreams, and I don't try to squash dreams, but we have to provide them with a lot of exposure and opportunity. Those are the two key words in the program. So what we would do with Bill A1311 is to really target career exposure in the healthcare industry to students, showcase the opportunities that are available so that they understand that healthcare does not mean doctors and nurses. Healthcare is much broader than that, and Taruna addressed some of those. We had a group of students go to University Hospital in Newark, and they had a whole slew of folks come in. It's teaching hospital, so they have an auditorium, and they had various folks come out and talk about the healthcare industry, and then the students could follow the individual that they would like to learn more about their career. And they had record keepers. You don't interact with anything yucky in record keeping, but the most popular was the lab tech, who got to dissect things that were excised from people's bodies. So that's the kind of thing that the students need to see. You can talk about it all you want, but having that kind of exposure is invaluable. So one of the other things that we'd like to do with Bill A1311 is to work with our existing schools and even expand to other schools that have CTE programs, career and technical education programs centered around healthcare. We cannot, with CTE, focus solely on hard skills. And I love that Taruna had all those different elements in her programs. What we need to do is also have these employability skills development programs, which is what JAG does. So if you dovetail CTE with what JAG does, you're getting that hard skills development, and you're also getting that soft skills development simultaneously, which will better prepare the students for these very in-demand industry sector careers. So that's something, and we heard Patty talk about it a little bit about the shortages in healthcare. And for our students, it's a numbers game. You have to showcase that there are X number of openings and there's projected to be, this many more, or this percentage of increase in openings in these specific areas of healthcare, and then explain again to the students, it may not encompass 12 additional years of education to become a surgeon. You can start by scaffolding, because there's this need for an immediate fulfillment of their personal needs in getting a job and having some income. So start out with a certification, go to a certification program, scaffold that so that you can build upon that skill set and go from, forgive me, I don't know the hierarchy of how these things work, but I know CNA could be a foot in the door that could lead to LPN, RN, and nurse practitioners, and on and on and on. And that could go tangentially into so many different directions as well. But if you have your foot in the door and you're starting to fill these in-demand sectors, then you have ample opportunity for advancement within your career.
Great. Thank you, Donna. And at this time, we'd love to have an audience question or two. So if folks have questions, put them in the chat box. I do have one more question of my own. Taruna, I'll start with you first. For us, with our workforce development work, we've definitely seen the connection between expanding diversity within the healthcare workforce and starting early and connecting folks. I loved what Donna, the terms you coined, opportunity and exposure. I mean, that's really key. So how do you see your programs helping to eventually increase diversity in the workforce? And what more could we as, collective healthcare entities be doing to help support you?
Absolutely. So I think on our end, we have partnered with several postgraduate programs. So we work with PA schools, PT schools, also medical schools. We have created linkages within our own medical school, where if students participate in our program, they have the opportunity to attend Cooper Medical School. But that's just one school. We also have partnered with other medical schools. So, if students are, let's say they cannot be admitted to Cooper Medical School, I will pick up the phone and call my colleagues at another school and advocate for that students. And I think that is the key with students. They need to have advocates. And I think that has been very crucial in the years that I've worked at Cooper Medical School in ensuring that we are able to support our students, not just have them have an experience in the summer, but follow them through until they graduate and matriculate into a program. So we've seen some great results with our program. Since 2011, we've had over 400 students that have participated in the program. About 80 to 90 of them have come back for multiple phases. And we've had over 40% that have matriculated at a allopathic, osteopathic, PA school, PT school, or a dental school. Now, we also still have a large number that are currently enrolled in college as undergraduates. What I think is important is partnerships and just not working in silos. And I think that's what sometimes happens in higher education institutions. Just like Donna's doing some great work, I would love to collaborate with her and offer opportunities for students that, you know, may not see medical school in the immediate future. Perhaps, as Donna mentioned, they may need to get a certificate first. They may need to work in an industry first and see if that's what, you know, they need to do in the future. So I think it's really important that we don't work in silos, that we collaborate with organizations, so with everything that's already existing. I feel sometimes we reinvent the wheel when we don't really need to. So that's my bit of, you know, advice in terms of what can we do collectively, you know, as a unit, because we have so many amazing programs happening in New Jersey and outside.
Great, thank you. We have just about a minute left. I do have a hand up from Ward. I don't know if he meant to have his hand up. I'm going to allow him to talk and see if he wants to ask his question live. Ward, if you're there, you need to unmute yourself. Seeing him, but not hearing him. So Ward, if you have a question, unmute yourself. If not, we will give you just a second.
He was an accident. Sorry about that, Tyler. So I appreciate the show. Thanks.
Thanks, Ward. I'm gonna unmute you. I'm gonna remove your hand there. So Donna, with that, would love to hear from you about what you think your programs are doing to increase diversity in the workforce as a whole, not just the healthcare workforce.
Sure. As I mentioned up front, the percentages of students that we have that are from underrepresented communities, we're in underrepresented communities. We're in Passaic, New Brunswick, Newark, Vineland, Little Egg Harbor. We've had programs in Camden as well. So we typically target school districts that have these low graduation rates, high populations of minority students, to really give them that exposure and opportunity again. And when we're working with employers, we try to do the reverse engineering of this so that the employers get to meet our students and know and understand. You know, if you describe our students, sometimes people get a little off put. We've got kids who've been adjudicated, kids who are gang affiliated, and it can be a little intimidating. However, our students, when we talk about youth of great promise, they have so much potential. They just do not have the traditional level of support at home that is necessary for them to flourish. They're very smart kids. They are very motivated. They have more tenacity than any other students I have ever seen. And I've worked with tens of thousands of kids over my career. And it's an often undervalued and overlooked student population. So when employers are recruiting and they meet our students tend to be better prepared. They're more mature. They are understanding what it takes to get and keep the job. So it's something that I would strongly recommend employers look at when they're looking to recruit. If you're having difficulty filling positions, and I'm not talking about healthcare because you need additional training for that, but entry-level positions, and you're not reaching out to some of these schools that could be very close to, we've got urban districts around the entire state, you're missing a tremendous opportunity. And especially if there's a JAG program in place, we look for and value those partnerships with area employers. And when we've had connections to them, the employers come back and ask, hey, do you have any more of those JAG students? They're really great. And you know, so-and-so moved on to go to post-secondary education. Now I have a position available, but I want more JAG students. So, you know, by virtue of the schools that we work in, we have a high minority population. And we're just teaching them what they need to know to be successful after they graduate.
Wonderful. Well, thank you both so much. I appreciate your time, and would hope that folks in the audience, if you'd like to learn more about Donna and Taruna's program, just reach out to us. I'd love to connect you. I think we made a connection between the two of you. So to the extent that you all can work together is wonderful. So thank you both so much for being here.
Thank you for the opportunity.
Thank you so much.
Okay, thank you both. And now we are going to send it to the next panel. Give me a moment here while I bring everybody forward. Our next panel is healthcare workforce well-being, and I am going to introduce our next moderator. Judy Schmidt is our next moderator. And give me a moment to get your panelists here. Okay, hi Judy. So seeing our new panelists are here, I think we're just waiting on Jean. I'd like to turn the program over to Judy. Judy is the CEO of the New Jersey State Nurses Association and the Institute for Nursing. Judy has received her associate degree in applied science from Ocean County College, a bachelor's degree in the science of nursing from Richard Stockton State College, and a master's degree in the science of nursing from Seton Hall University, and a doctoral degree in healthcare administration, health policy from the program at Capella University. So thank you all for being here. Judy, I'm going to hand things over to you.
Thank you, Tyler. It is my pleasure to be here today to introduce these wonderful speakers for our second panel. And I do apologize up front if I mispronounce your names. So our first panelist is Jean Rubel. Jean is the Chief Administrative and Talent Officer for Parker Health Group, Inc. Jean is responsible for aligning talent and organizational performance efforts to strategic imperatives at Parker. She established a talent philosophy to drive decision-making and resource allocation in support of Parker's employee value proposition. As a member of the executive leadership, Jean led the organization through COVID-19 pandemic, ensuring that all employee care partners remained fully employed and were well informed, engaged, and resourced to deliver on Parker's mission. Our second panelist, Roy Letstein, is the CEO of Legacy Treatment Services. Roy has served as the Chief Executive Officer of Legacy Treatment Services since its inception. Excuse me. He has a bachelor's degree in psychology and a master's degree in human services. Roy began his career in social services while serving in the United States Army and volunteering for the Exceptional Family Member Program. Legacy Treatment Services is a nonprofit behavioral health organization serving more than 16,000 people each year. Legacy operates over 70 programs across the entire state of New Jersey. Services include prevention programs, outpatient therapy and psychiatric services, substance abuse programs, emergency and crisis intervention services, therapeutic foster care, juvenile detention alternatives, residential programs, case management services for adults and children with developmental disabilities, and a special education school. Legacy Treatment Services programming aims to change the behavioral health and social service outcomes for people of all ages, from surviving to thriving. Wow, that's wonderful. That's a lot of services there. So welcome to you both, and thank you for joining us. So for our first question, I'm going to go to Jean. The long-term therapy industry was among one of the hardest hits by the pandemic. What have you done at Parker to support the mental and physical health of your staff?
Hi, Judy. Thanks for the introduction, and it's good to be with everyone today. I think like most providers, we like to think that we put our employees and in our case, our care partners at the center of all we do, because after all, if they're well cared for, they'll care well for our elders and our participants. But of course, at the beginning of the pandemic, and especially through that first year, all of our care partners were experiencing both personal and professional crises, whether to go to work, whether to stay at home and kind of be safe, if you will. So one of the first things we did was really try to make sure that people knew that we would take care of them while they were here and make sure that they were prepared with all the basics, the PPE, for example. But then we also looked at From an employee assistance program perspective, we made sure that we expanded our employee assistance program services. We also expanded our medical benefits to include virtual mental health counseling and services free of charge. But we also knew that our employees, because they're care partners, they're very busy taking care of others, and they generally will put themselves last. So we thought we would bring the well-being checks to them. So I partnered with our Director of Social Services, who put together a wonderful program, a very simple program to go into our homes. We offer the programs both virtually and in person in very small, socially distanced settings to really just check in on people, to ask them 3 important questions. What's most on your mind right now? How are you feeling? And what are you doing to take care of yourself? And because people are generally not, they weren't good at being vulnerable at that time, because I think their nerve endings were right here. And had they said anything, they would have, there would have been a flood of emotion. We allowed people, a variety of venues to be able to, or media to be able to express themselves. Some people spoke out loud. Other people were offered the opportunity to journal, and they wrote things down and share if they wanted to. What we found, though, is people really weren't taking good care of themselves. So we offered them a group setting to talk about what you can do for self-care, from really kind of big things around, eating healthy, exercising, doing things, or just literally getting out of the building where you're taking care of elders and go outside for a walk and get fresh air, and giving yourself permission to do that. And then we put processes in place where our managers would walk around our homes to make sure that people were having the opportunity to do that when they were working, in very difficult circumstances. What we found was we went to our managers of people first. We offered them those sessions first, that they could then speak from experience and encourage their own staff to do the same and participate in those well-being sessions. And we had about 100 people take advantage of it out of about 750 of our employees. What many said was, I didn't realize how badly I needed this until I actually sat down and took 15 minutes, a half an hour to just take care of myself. So we had some great success with that. And then we put some really practical tools in the hands of the managers to continue having those conversations with people on a one-on-one basis. That was a pretty heavy time for us. We got through that next year and a half. And what we started to do more recently is really start to introduce more fun back into the workplace. That was a really big part of the fabric of our culture. And that all just went away during the pandemic. So we've reintroduced fun and spontaneity, which is a big part of the way we care partner with our elders. We had, prior to the pandemic, offered free Zumba classes in our homes, and we just recently introduced that as one of the things that we do to help take care of people's physical health as well.
Those are great initiatives that you put forth during the pandemic for your staff. Roy, similarly, the pandemic dramatically increased the need for mental and behavioral health services. What were some of the ways that you've done with your staff to give them a reprieve from the challenging work, since they are the ones that are working, in mental health and behavioral health services? So what are some of the unique ways you helped your staff to give them a reprieve from that work?
Thanks so much, Judy. I really appreciate it. And Jean, just like you, it was a really trying time when the pandemic first hit, and as we worked through that, right? And I think really, for the folks that are attending, what I would say is we have to be as passionate about taking care of the people that we work with as we are about the passion that we have for the people that we serve. Because if we're not helping them, if we're not appreciating them, then who is? And so really what we did was we treated it like family. And so we stood what was our traditional incentives, right, or ways to help staff on its head. And the running theory was there should always be something next. So it was not an easy task, but for example, we gave out, we have about 1,000 staff. We gave out $100 gift cards to movie theaters, right? So if you remember during the pandemic, movie theaters were struggling, you could rent out the whole movie theater, right? And so that's what we did. We went and we said we would give out 100 of them. We had 300 responses, so we got 300. So every single person that replied that they wanted to do it, and it wasn't just for our staff, it was for our staff and their families. So every person had the ability to bring up to 8 people with them to the movies. We did escape room, axe throwing. Our organization was adamantly opposed to the selling of Girl Scout cookies. Why? Because Girl Scout cookies become very competitive. One person wanted to do it, then someone else wanted to do it. But we stood that on its head. We sent a survey out to staff and said, any staff that are interested in selling Girl Scout cookies, please let us know, right? They had their family members, right? Their kids that were selling them. And then we purchased a box of Girl Scout cookies for every single person that worked in the agency from the children of our staff, so that they would benefit from it. And there was a handwritten note to all 1,000 folks from their immediate supervisor, letting them know how much they were appreciated. We did the same thing with popcorn. Every Double Good popcorn, I don't recommend anyone get it because it's highly addictive, but that popcorn's phenomenal. And we did the same thing, right? We reached out, we purchased, there was an organization doing a fundraiser. We purchased a bag of popcorn for every single person in the organization. And what we found was those efforts, the recognition of staff and the lives that they had outside of work and the families that they have, right? Understanding who your workforce is, what makes them tick, and treating them as a whole person was simply astonishing, the results that we got. And our staff was more vocal about that feedback, right? And then the other thing we did, Judy, was we changed our lines of communication. Prior to the pandemic, when we were communicating with the organization, we would do an email. We would send a mass email out to staff, right? But then when we looked at the data, right, not everybody was reading the email, right? It was like 10% of our staff were reading emails. We're like, well, effective communication isn't my sending a message out, right? It's got to be received. And so we changed our communication paradigm. We started doing text trees. We still did email. We did in-person meetings where we could. And then we also created an all managers meeting with about 150 of our staff, right, where, and it wasn't a traditional agenda. It was a back and forth. It was an actual communication between staff and administration, so that we could work through challenges and make sure folks understood that they were appreciated.
Those are great ideas, Roy, that we can all use in all our different workplaces. And I think one of the key points I took from your is communication. That you can communicate one way. You're hoping that your employees or your workers are listening and are reading their emails or whatever. But yes, communication is a two-way street, and you really have to know if that employee is actually hearing what you're saying or receiving, reading, or whatever your communication. So that's all fantastic work that you did during the pandemic. So Jean, what more do you think we as a state or as a healthcare industry can show healthcare workers that they are valued during non-emergent time and kind of help relieve what we've now called compassion fatigue? In the past, we've called it burnout, and there's probably other terminology that we're using today. But what do you think that we can do to show healthcare workers they're valued during non-emergent times?
Sure, Judy, I think it's a really interesting question, and that the whole concept of compassion fatigue is this giving of oneself. And so I think something Dr. Boyce said earlier, and then Roy, something you just said around, you have to take care of the people who take care of the people. And then there's, what Dr. Boyce said is really shifting to being more person-centered. And that is really foundational to the work that we do here. So at Parker, and I think it's it's not unique, but we've really doubled down on it in the last number of months to get back to that, get back to those basics of being person-centered for our employee care partners as well as the people we serve. And the reason that is we really lost focus on it as an industry because frankly, some of the regulations that we had to employ and be compliant with were not person-centered. So you have to be really purposeful about getting back to that. And we've redefined for Parker what it means to be person-centered, and we've made the definition really global in that it's everybody who's part of our community. And I think if employers can be really purposeful about, as an industry, taking care of the people who take care of the people, it makes people feel appreciated and also creates an environment where people can come in and do their best work. And we're doing a lot of work in leader development, which I think, unfortunately, it's expensive, right? So the industry isn't really resourced well to focus on leaders. And what happens is you have, great individual contributors who are great technologists, and we say, wow, you're great, let's promote you into a managerial position. And then we say, go do good stuff. And we don't train them really well to be managers of people and leaders of leaders. And so as an industry, I think we really need to focus on that, because what makes you a successful individual contributor sometimes can make you an abject failure as a manager. And then you have to learn new skill sets and acquire new skill sets. So we're really focusing in this kind of as we have come out of the crisis of the pandemic and got into a more normalized workflow, really gotten back to the basics of focusing on manager development and leader development in terms of leading oneself, leading individuals, leading teams, and leading an enterprise, and really with a real focus on the people. We need people who are good managers of the business, but you also have to be a good manager of the people. And people will come to work and stay where they feel appreciated and where they can contribute to the best of their ability. And I often say to my team, my job is to make sure you have all the tools you need. I keep developing you, and I smooth the road ahead of you and take all the roadblocks out of your way. That creates a really engaging work environment. So we are focused on being a high quality organization, fiscally responsible, compliant, but at first and foremost person centered. And that includes our employee care partners as well. I think being compassionate and treating the whole employee care partner is really important. It used to be when I first started work many ages ago. You would check your personal life at the door and don't bring your problems to work. And I think as employers and as an industry, especially and employers of healthcare employees, we have to treat the whole person and really understand, what people are dealing with. Because when people show up late to work, it's not because they plan to come to work late. It's because there's something going on at home. And so, Roy, I really appreciated what you talked about in terms of engaging the whole family, because that family are the people who enable your employee to show up at work every day, either really engaged or not really engaged. And I think lastly is being purposeful about paying a competitive wage. We have to make it such that people don't have to work 2 and 3 jobs to put food on the table. And so as an industry, it's important that we are competitive with other industries. We didn't used to have to compete with Amazon and Burger King and Target, and now we do. And I'm sure, just like the folks on this call, we all see the big banners hanging outside lots of different businesses, hiring today on the spot interviews starting at $20 an hour. Our work is really hard. Besides being, running into compassion fatigue, it's messy. It can be ugly at times. And so we really have to take money off the table as a dissatisfier so that the work becomes a satisfier. But that dynamic of people working, several jobs to put money on the table, pay the bills, pay their gas bills, and then put their kids through school is really difficult. And if we can move the needle on that as an industry, I think we'll attract a lot more people. It also will help with the kind of the churn of talent from employer to employer and moving for a buck. And that's what people are doing because it makes a difference.
Thank you, Jean. Roy, do you have anything you want to add about what we can do to show our healthcare workers that they're valued and hopefully relieve some of that compassion fatigue?
Sure. When we're not in the crisis is when the work is really done, right? Like you're putting in all of those investments, right? And all of that effort. So a lot of what I would say would mimic what Jean did in terms of career ladders in that regard. But one of the things that we do is our staff is very aware of our advocacy efforts, and I hate to tie everything to finance, right? But in healthcare, the reimbursable rate really drives a lot of what we're able to do and what we can afford to do. And so when staff understand that we're with them, that it's not that there's not a segregation between, honestly, the CEO and a direct service professional, right? I worked direct service for many years. So what we have found to be very helpful is to advertise our advocacy efforts, and what we are constantly trying to drive home is reimbursement rates that move according to inflation. And so, you know, everyone's talking about 8.5% inflation, right? But the cost drivers healthcare providers have are much higher inflationary rates, right? You know, literally the cost for healthcare, right? Benefits, they go up 20, 30% a year easily. So, and what we really try to do is say, hey, you know, just about every penny that we get in an increase goes directly to the workforce, right? So for us to be able to change those compensation rates. So that's something that we have found very helpful. And then the other piece is, you know, I recommend Marcus Buckingham wrote a book 25 years ago, First Break All the Rules. Maybe it was 30 years ago. I think it was on the Time Magazine's 25 most influential books of all time, right? And at the end of the day, what it says is your staff, treat your staff as individuals, treat them as one person and get to know them as one person, and that people work for people. And so that's really what we do in the downturn, right? In the downturn, what we do is we take the time when there is no crisis to get to know the folks that are working with us, get to know what their motivations are, what really are their incentives, and then we build resources for all of that. So if every single one of my staff have access to a financial planner, anybody who works for Legacy can meet with a financial planner and they'll put together a plan for them, right? That type of thing, Judy.
Thank you, Roy, and thank you, Jean. They were both fantastic ideas to show that we do value our healthcare workers in both the emergent and emergency times and the non-emergent times. Jean, I think we have time for probably one more question. Jean, there is a significant demand for more certified nursing assistants, and Dr. Boyce went through that in her presentation. And Parker, I know, relies very heavily on their certified nursing assistant workforce. So what has Parker done to expand their workforce over these past few months?
Sorry, I had myself on mute. Great question. It's the CNAs are, you know, the heart and soul of the work that we do here at Parker, and most organizations do in long-term care and working with elders in particular, and have such a tremendous impact on their quality of life and their ability to live their best lives. And we have struggled, as most organizations have, at there's a finite number of people who do this work, and there's way more jobs than there are people, and so you can only cycle through this, you know, the same group of people for so long. So a number of years ago, actually, about 4.5, 5 years ago, Parker decided to kind of take the bull by the horns and said, we're going to grow our own. And so we created our own CNA school. We have one full-time instructor who is one of our educators, and we have the ability to run a school out of one of our homes that actually supports all of our homes for up to 10 candidates at a time. And it's not a panacea, and it's not a cure-all, and we don't, I'll be perfectly honest, lessons learned is we've had way more success with internal candidates than external candidates. And I think part of that is because you have a chance to observe people in other roles, environmental services, dining, recreation, and watch for their connections with the elders to see if culturally they're really committed to doing this kind of work and have an aptitude for connecting with the people who we care for. And we have 100% success rate with those people. We have a much lower success rate with external candidates who we hire full-time. offer them training, and then give them the ability to kind of, work in the homes in a non-clinical capacity while they're training. We've built the program such that it's 3 days a week, but we offer a full-time schedule at 5 days a week to give an opportunity to get tutoring, to we give them a study space. They form study groups. The groups take it really, really seriously. The last group that we graduated finished up in December. They took their certification test in January. They all passed, and we guaranteed them full-time jobs for a variety of reasons. One, we wanted them to know we were committed to them, but also because it takes a while to build the skill to get really comfortable, and doing it part-time or even per diem doesn't give the CNAs the exposure and the hands-on experience in a really consolidated way that they need to build those skills. But we're actually in the process of launching another program. We're doing one in June. It'll be about half external candidates, half internal candidates. What's wonderful for us, though, is as we're recruiting dining employees, recreation assistants, and EVS candidates, we can speak about this program with confidence that if you're successful in your role and you choose a career in nursing, there's a stepping stone for you here. So it's a really nice way for them to learn Parker, learn elder care and elder services, and then make an informed choice about getting into the world of being a CNA, because it's not for the faint of heart, right? These are really hard jobs. But they work alongside, in our small home model, they work alongside the CNAs every day, and they see how that work is done and what's required of them. So they're really making an informed choice about throwing their hat in the ring into a competitive interview process to be selected for that program.
Jean, it's a very innovative program and a very personalized education program to get more certified nursing assistants. So that's great. At this time, I don't see any questions in the chat or anything in the QA. So what I'm going to do is thank Jean and Roy for all their wonderful comments that they had and all their innovative programs and their support for their staff that they had during the last 24 or so months. So at this point, I'd like to turn the program back over to Linda to wrap things up.
Great. Thank you so much, Judy and Jean and Roy. Really, it's great to see all of you, and I appreciate your participation in today's conference. And to thank you to our other panelists and our keynote, Dr. Boyce. And thank you to all of our members and other participants today. If you're not a member of the Quality Institute and you're interested in joining us, please reach out to any of us. We'd love to tell you more about the Quality Institute and the work we're doing. Stay tuned. We are going to be releasing a number of reports over the next few months on the various quality, safety, and affordability topics that we work on. Also, as we say goodbye, you're going to get a survey on your screen, and we really would appreciate you taking, it's a very short survey, just if you could take a minute just to fill it out so we can make sure that we are as responsive to your needs as possible. So again, thank you, all of you, for participating. Thank you to the Robert Wood Johnson Foundation for its support of our healthcare workforce initiative. And if you have further thoughts on this important topic, please don't hesitate to reach out to any of us, and have a great rest of your day. Thanks so much. Bye-bye.